We'll get started here with some introductions. I'm Josh Richardson. I'm a psychotherapist with Grey Bruce Health Services. I'm very happy to welcome you to this presentation from Louisa Marion-Bellemare and Julie Samson, buprenorphine macrodosing in the ER and early depot buprenorphine initiation in the hospital setting. I'll just remind you that there will be a question and answer portion at the end of the session, 15 minutes toward the end. And there's a help button in the lower left in case you need any technical assistance. And a reminder to do the evaluation for this session. I'll put it in the chat later on. Please, if you have any questions, put them in the chat as well, and we'll take them up at the end. Dr. Louisa Marion-Bellemare graduated from and completed her residency at the Northern Ontario School of Medicine. She works at the Timmins and District Hospital Emergency Department, Pediatric Mental Health Department, the Primary Care Clinic at the Homeless Shelter, and the Addictions Clinic in communities along the James Bay coast. Dr. Marion-Bellemare can also be found working at the Indigenous Healthcare Center and the local provincial jail. She is the co-lead and works with the addiction medicine program at the hospital, which includes the addiction medicine consult service and the community withdrawal management service. She is actively involved in her community by promoting barrier-free access to addiction treatment with the ultimate goal to save lives and improve quality of life. Dr. Julie Samson graduated from the Ottawa University Medical School in 1995 and completed her family medicine residency in the Northern Ontario, in Northern Ontario, and her EM certification in 1998. She began her family practice in Timmins, Ontario in 1999, where she also works in the emergency department and as a hospitalist. She recently started working at the local shelter primary care clinic. She's actively involved with the opiate crisis in her city, advocating for better access and improved care for people living with addictions. As co-lead of the addiction program at her hospital, she works with the acute medical withdrawal management service, addiction medicine consult team, and community withdrawal management service. She also works in outreach addictions clinic in communities along the James Bay coast. And so, without any further ado, I turn it over to you too, Julie and Louisa.
Well, well, thanks for that introduction, Josh. You made us both sound really smart. So we appreciate that. So good morning, everybody. Thanks again for coming to our talk. We're going to get started this morning. Josh already discussed with you our title. For those of you who don't know, that's Bob Dylan in the back of our title slide. Okay, so with respect to disclosure financial support, we have received no financial support. This program has received no in-kind support, and there's no potential conflicts of interest. Oh, shoot, sorry. It's a bit of a delay. There's a bit of delay, sorry. This is us, faculty is us, and the relationships, Speakers Bureau Honorarium was from the CSAM Conference, actually almost a year ago, 2021, and Master Clinician Alliance Harley Street Talk in November of 2021 and February of 2022. And mitigating potential bias, of course, the content here is based on clinical experience and therefore includes off-label uses. And, you know, Julie and I talk about this, with respect to the toxic drug supply, it's evolving so quickly in front of us. You know, we don't have a lot of evidence at this point to support all parts of what we're doing. However, we will show you some evidence that does exist, although it's not super robust. Learning objectives, we're going to discuss macrodosing options for initiating buprenorphine naloxone in the emergency department for people with opiate use disorder. We're going to discuss early depot, so that's the injectable form of buprenorphine administration in the hospital setting. And again, these are both to improve survival and retention to treatment and improve healthcare provider comfort with initiating both of these things, both in our emerge and in our hospital setting. Timmins. It's about a population of 42,000, very, very vast geography. Actually, geography-wise, we're one of the biggest cities in Ontario, believe it or not, but population-wise, we're not. Home of Shania Twain, Bill Barocco, Steve Sullivan, Frank Mahovlich, and, the Lou Jew. Okay, I'm going to let Julie take over now.
So the opiate crisis and time for change, and when Louisa and I looked into this in 2020, we knew there was issues in our department. We've been working, Louisa, for about 8 years in the emergency department, and I've been here for 23 years. In the last 5 years, there's been a huge exponential increase in opiate-related deaths in our city. We knew this, but it's not until we looked at the stats that we realized how bad it was. These are the most recent stats we have from 2021 as a public health unit. Timmins is about the third worst in northeastern Ontario. It was worse the years before, but unfortunately Thunder Bay has surpassed us last year, and they've had a big crisis there in the past year. But our health unit as a whole, all in northeastern Ontario, the 5 health units are the worst in the province. As for Timmins itself, when we look at our own city for our population of 42,000 or 100, our per capita death rate is quite high compared to the rest of the province. Since 2017, you can see in the green an exponential rise in the opiate-related deaths in Timmins. Our per capita death rate in 2021 was at 80, compared to Ontario, which sits around 19 in terms of death rates from opiates. In Vancouver here, Vancouver East Side, you can see that it stayed about the same in the past 5 years, a bit of an elevation at 49 here in 2021. So we're almost double what's going on in Vancouver. And that's when we realized in 2020 that something needed to change. Again, this is from the Ontario Public Health website, just demonstrating what we all know, that fentanyl is the #1 cause of opiate-related deaths. It's found in most opiate-related deaths, now often mixed with other things more recently, crystal meth, benzodiazepines. But fentanyl is one of the major causes and found in the postmortems. What's important in this graph to see is that drugs that we use all the time from an emergency point of view, because we're coming in this, showing this presentation from an emergency department view, is that drugs that we use all the time, such as Dilaudid, which is hydromorphone, Percocets, morphine, Tylenol 3s, codeine that we prescribe all the time, are also causes of opiate-related deaths. And buprenorphine here is barely ever seen, 0 pre-pandemic. And yes, they found a trace of buprenorphine in 2 cases, but overall, it's a very safe drug, and we'll talk about that later. This is very important as well as part, when related to emergency departments. Healthcare use among people who died of opiate-related deaths during the pandemic saw that within 7 days of their death, the most common area that they were seen in the healthcare was the emergency department. This points out how important it is as an emergency physician that if you see a patient with an opiate-related opiate use disorder, they need to be treated. They come to us over anywhere else and access healthcare there all the time. So we need to be able to offer them help when they present to our emerge departments.
And this slide also shows that at some point, most people who died of an opiate overdose 7 days before their death, over 18% of people had been in contact with a healthcare provider. And they died within 7 days. So just to realize the importance that we need to start, we can't ignore it, and we need to be comfortable with acknowledging
they're not hiding. They're not hiding. They are coming to us all the time.
Yeah. So some of the things that we heard in our emergency room that sort of triggered Julie and I saying, okay, we need to change something. This cannot keep on happening. People coming in and overdosing and sending them out, or people coming in and dying who otherwise should not be dying from overdoses. People were saying things like, what's going on in our city? It's never been this bad. And there was truth to that. Anecdotally, we thought it was bad. And then when we actually looked at our numbers, we realized, as we showed you earlier, it was as bad as we thought it was. Here we go again. So-and-so's coming in. It's his third overdose of the week. He was in respiratory arrest and now breathing. You think he would make him stop using drugs if he's overdosed 3 times this week? Why is he still using drugs? And then Julie and I both said, we need to be part of the solution. We need to stop blaming the patient. We need to blame the system. If they are coming to see us, and we know that by that previous slide, why aren't we changing what we're doing to help people in our emergency department?
Because what we were doing was nothing.
Treating and treating them.
Yeah.
So we're just going to show you a little video here.
Push on this one more time.
Okay. Last night, around 4:30 last night, my friend He was just standing there, and then he got wobbly, and then he fell down, and then blood came out of his nose. He stopped breathing.
We need to improve our addiction system. And we all know that at this point. We need to figure out how we're going to do it.
We are doing the worst in terms of death rates in Ontario, and I could even argue possibly nationally. And this is just in Timmins, not even Timmins an area.
I think we all agree that the status quo cannot continue, and that our inactions are actually contributing to people's deaths. We have to act now to change how addiction services are delivered. We need to come together with the primary goal to decrease mortality. We need to decrease deaths in our community.
So the purpose of that video, and Julie and I needed this to prove to ourselves and to prove to people in our hospital, to prove to our community. Julie and I made this a hospital and a community problem. We decided that as a community and a hospital, this could not go on anymore. Otherwise, healthy young people were dying. We needed to make people understand that addiction isn't, an untreated addiction is life-threatening. We know people who aren't treated have a very, very high risk of dying. We know that those who come in with non-fatal overdose to our merge, so those are the ones that are reversed on Narcan or who, we let them sleep it off. We know that every time an overdose, non-fatal overdose happens, the risk of death goes higher and the risk of a fatal overdose goes up substantially. And we know that when people come in and ask us for help in our emerge, it's a fleeting moment. When they are asking us for help, that is the time we need to get in there and have a discussion with them and talk to them about treatment, because it's usually at the point in their life where they're really, really at the bottom. They've hit rock bottom and they want help, and we need to take care of them. When we look at overdose and short-term mortality, these statistics are staggering. There's a 5% one-year mortality post-ED discharge. So when someone comes in and sees us with an overdose, non-fatal overdose, their risk of dying within that year is 5%. Of that 5%, 20% of them die within the first month. And this is even more staggering. Those who died in the first month actually died within 2 days of leaving our emerge. We have to remember that within 2 days of leaving the emerge, the chances of someone dying from an overdose death is almost 40 times that of someone dying of a cardiac arrest who presents with chest pain to our hospital. When we look at practice guidelines for the treatment of opiate use disorder, I think the major take-home messages from this is that for severe and moderate withdrawals, the first line is Suboxone or buprenorphine within 2 hours. Whether they want to be on methadone later, that doesn't factor in here. This is someone who's in severe and moderate withdrawals presenting to your hospital or even presenting to your clinic. Buprenorphine, Suboxone should be administered. These clinical practice guidelines came out by Health Quality Ontario in 2018. First line treatment is with buprenorphine naloxone. And if for those who come into your department who aren't in withdrawal and asking for help, they should be seen within 3 days, maximum 3 days of getting help. These are guidelines set out by Ontario, and a lot of our communities are not meeting these guidelines.
And we weren't meeting them either, right? We didn't know about this until we looked into it in 2020, and it was kind of embarrassing. We're like, what? We didn't even know these existed. So really, when we think about it, where can withdrawals be treated within 2 hours, 24/7? It's pretty obvious, the hospital, right? There's tons of great addiction services out there in Timmins, but they can't be open 24/7, right? So the only place that this can be done is the hospital. There's other places too that we might talk about later, but the hospital is the number one place that this can be achieved. So the other health quality guidelines, HQ guidelines, talk about length of treatment, talk about cold turkey. That means no opiate agonist therapy for withdrawal management. We know that the relapse is 60 to 90%. So at all costs, if we can, we need to offer treatment patients to patients who are requesting
and even if they don't stay on treatment, we can offer them treatment and emerge even if you give them one dose of buprenorphine naloxone emerge and they leave, you've still protected them. And that's what we're going to prove to you today. It's a safe drug and it offers protection.
And you can't expect patients to remain on treatment if they're not offered treatment. So we all have to be doing this in the emergency department now. CAPE, which is the Canadian Association of Emergency Physicians, put out a position statement in 2020 when we first started doing this, October 2020, stating that in the emergency department, first-line treatment, buprenorphine should be offered to anybody presenting in withdrawals and should be done by all emergency departments. And what this does is it expands the opportunity for all these patients who come to our emergency department to be initiated on treatment. And we know that buprenorphine cravings and withdrawal symptoms are well controlled on this. And we also know that it prevents relapse, like all opiate agonist therapy, and reduces overdose and therefore mortality.
And Julie and I actually just presented in Spain about similar about treatment of people with opiate use disorder, and it was to emergency physicians. And we said, how many people, these are do you know about this CAPE position statement?
Very few knew about it. And these are Canadian emergency physicians.
So we need to be, but yet if there was a position statement put out about how to treat people having heart attacks,
we'd be all over it.
We'd be all over it. We just proved the point that as emergency personnel, as people in the hospital, we need to be taking better care of people with opiate use disorder.
In the States, they're a bit ahead of us. Andrew Herring is an emergency physician in the States that's doing a lot of research regarding this. But I mean, what he's presented many times, that untreated opiate withdrawal commonly results in return to high consequence opiate use with high risk of overdose death after discharge from our emerge department. We need to be treating patients in the emergency department. Treating them and treating them with just naloxone is not an effective treatment in the emergency department. We need to stop. We know that less than 20% of patients who need opiate agonist therapy were started in the emergency department, despite the evidence that it's life-saving. And then we know that when it is administered in emerge, about 74% remain in treatment after 2 months and 70% sometimes up to after 1 year. There's no other place, like we said, that allows access 24/7 to this treatment for patients who are requesting
and it's a simple treatment
any time of the day, right?
Yeah.
So an emergency department improves the access for this treatment to all patients requesting it. Okay, so why buprenorphine? Let's go over a little numbers needed to treat here to make you realize how easy it is.
And we'll just explain, because some of you may not be physicians listening today. When we look at numbers needed to treat, we're looking at the numbers it needs to treat to save one life or remain somebody to remain in treatment. So the number of times we give this medication in order to save one life.
So we always talked about NNT numbers need to treat for chest pains, for heart attacks, for strokes. So for this is a treatment for heart attacks called thrombolytics. The numbers needed to treat to prevent one death with thrombolytics. You need to treat 43 patients to prevent one death. The numbers need to treat with aspirin for a stroke to prevent one death at a month or dependence. You need to treat 79 patients to prevent that with aspirin. Numbers need to treat with aspirin for a heart attack to prevent one death at a month is 42.
And we give everyone aspirin. Everybody.
Chest pain, right? Yeah. Because it's cheap, it's easy, and you could prevent a death, one death, if you treat every 42 patients. Numbers needed to treat to allow a patient to remain in treatment. When you start buprenorphine over 16 milligrams, number of patients you need to treat to promote one patient into treatment.
Wait for it.
2. I mean, this is unheard of, right? We should be using buprenorphine like candy when patients present to our emerge department.
So what we say is gone are the days of Tweeter and the Monkey Man. And for those of you who know the traveling Wilburys, and oh my God, he's drawing a blank.
Oh my God, this is your slide.
You guys, I'm drawing a blank of the lead singer of Tom Petty. Oh my God, this is terrible. Oh, yeah. So Tom Petty, the interesting story about this is, I don't know if you guys know the song, Tweeter and the Monkey Man were hard up for cash. They stayed up all night selling cocaine and hash. The point is, the days of treating people with just cocaine addiction or cannabis addiction, it's not the same. The way we need to treat addiction today is it must change. We need to meet people where they are at along their journey of their addiction. We cannot be using cookie cutter approaches. We cannot be doing the same thing for everybody. We have to look at the patient and go through their goals. Tom Petty died at 64 years old of a fentanyl overdose. And I say that because this is a guy who used heroin his whole life, cocaine his whole life. And at 65, to show you how addictive these drugs are and to understand how difficult it is and how people need our help to stop using, however that may look, that even Tom Petty died of a fentanyl overdose, the power of the addiction of that drug. When we look at Keith Richards and Mick Jagger, they're called the Toxic Twins, the Chemical Brothers. Why do you think that they have not died? They used heroin for many, many years of their lives. And in the last, and they're now 80 years old, but unlike Tom Petty, they did not get into fentanyl. They stopped using IV drugs in their 60s. And the sad thing is Tom Petty, unfortunately, continued to use IV fentanyl and died from it. Heroin was a much more predictable drug. It wasn't contaminated. People knew what they were getting. They could predict the withdrawals. Fentanyl and its contaminants is unpredictable. People don't know what they're getting. So this is Keith Richards, and this is true. He was interviewed on a British talk show, and he was sitting there and he said to the talk show host, "That's right, bitches. I made it another year." And he himself, he doesn't even understand it, but he contributes many of his successes now to the changes he's made in his lifestyle. So how safe is buprenorphine? This is what Julie and I want you to understand. Suboxone is safe. Fentanyl is what's killing people. People say things to us, well, if I give someone Suboxone, do I have to monitor them? If I give them too high of a dose of Suboxone, we say to people all the time, people are using off-label use of fentanyl every day on the streets. People are using fentanyl to drug that they don't even know what's in it half the time that they're getting the percentage of fentanyl. When we give somebody Suboxone, we know what's in the drug. We know it treats their cravings and withdrawals. And people worry it's a partial opiate agonist. It cannot cause respiratory depression. We have actually given people doses over 90 milligrams, and we have never had respiratory depression in a patient. If you can see here that the prescription drugs that we use every day, morphine, Tylenol 3s, the more and more we give, the more and more we increase their risk of respiratory depression, meaning they're what kills people when they use opiates, that they stop breathing and they die. That's what kills them. The thing is, Suboxone will never reach that threshold. You don't stop breathing and dying when you use Suboxone. The nice thing about Suboxone is how long it lasts. The goal is to use over 16 milligrams. 16 milligrams protects people from overdose and death for 24 to 48 hours. And these patients may decide to not stay on the treatment. When they come into your emerge in severe withdrawals, reversed on Narcan, you need to treat them in order to move forward and have a discussion about what they want in their lives. When people are vomiting, uncomfortable, shaking, just thinking about they want to leave your emerge, you have to get them comfortable to have a discussion. We offer them Suboxone, they take it, we have a discussion, just like someone who comes in with crushing chest pain from a heart attack. What do? We treat their crushing chest pain with medication to have a discussion about their further treatment. Some people have crushing chest pain and have a heart attack and decide, you know what? I don't want to go to Sudbury and see the cardiologist. That's fine. But we need to get to a point where we can even have a discussion with these patients. And Sublocade can last much, much longer, 2 to 6 weeks. So the goal is to give higher doses. These tiny little doses of Suboxone does not work in the fentanyl era. And that's why people think Suboxone doesn't work.
We'll talk about our protocol soon about that.
So what is this still me? Yeah. What is, people fear precipitated withdrawal. We're not going to talk long about this. This is when you give somebody, and I just want to clarify this, when people go into what's called precipitated withdrawal from Suboxone, it has nothing to do with the naloxone. The naloxone and Suboxone is only to prevent people injecting the drug. It has nothing. This is not what creates people going into withdrawal. What actually happens when you give Suboxone is people get this sensation that they're feeling like they're in withdrawals, because Suboxone is only partially stimulating the receptor, the opiate receptor, versus a full opiate like fentanyl is fully stimulating the receptor. So when you give Suboxone, it kicks off the fentanyl, if there's fentanyl on there, and it makes people feel like they're in withdrawals because you're not fully stimulating that receptor. So the worry for a lot of patients is if you take Suboxone too early, you put yourself in withdrawals, and it is a true worry. So we usually ask people to try to be at least 18 to 24 hours after fentanyl use before they start Suboxone. And many people have used Suboxone on the street. Many of our patients will say, look, doc, I take 16 milligrams or I take 24 milligrams. If they say they do that on the street, they buy Suboxone, we give them that in the emerge. If someone says to me, I take 24 milligrams, We're like, okay, here's 24. They know what they're taking. They know what they need when they come into our emerge. And this is just to explain to you a little bit more precipitated withdrawal. You know, when you have an opiate on there normally, and you go and take, and when you have an opiate on, it fully turns that volume button on. The receptor in your brain is on, you feel great, you have some euphoria. When you take Suboxone, it kicks it off. When you kick off that fentanyl, it makes you feel like you're in withdrawal. And then when the Suboxone attaches, or I should be saying buprenorphine naloxone, sorry, attaches to the receptor, it only partially stimulates it. So that volume button is only half on. So people kind of feel kind of crazy. Sorry, uncomfortable, not crazy.
She's crazy
Uncomfortable.
right now.
I'm crazy. They can feel uncomfortable. So then what happens is you have to give them more Suboxone to get rid of that feeling. So when we look at treating precipitated withdrawal, the answer is more Suboxone. The more Suboxone we give, the more we stimulate the receptor, the less people feel sick, and it does take some time. But when people have really bad precipitated withdrawal, if they take that Suboxone way too early, then
we treat it with more buprenorphine.
We keep giving more, but then
Yeah.
sometimes you got to give them a few other medications if they're really uncomfortable. And sometimes I give them, believe it or not, a little bit of Statex, morphine, to make them feel better. But anyways, when you do treat it, the ultimate treatment is more buprenorphine.
We've given routinely 44 to 52 milligrams in patients who unfortunately went to precipitated withdrawal, and they do fine. There's no respiratory depression, and they feel better.
Way better. And then we drop back down. So
Yeah.
we have to go up to 54 to get them through the precipitated withdrawal. We go get them up to 54, and then we bring them back down to
The
32
next day.
when they're feeling better. Okay, so, and I just want to say that Suboxone is very safe in pregnancy. We have used it on several occasions in pregnancy. So Julie and I like using this quote. This is John Lennon, watching the wheels. And the reason why we do is, you know, Julie and I say, people are always asking questions, lost in confusion. Well, I tell them there's no problem.
Only solutions.
So, you know, our argument is when people are always saying things like, oh, how are we going to treat these patients? And what are we going to do with these patients in our hospital? They're taking up beds. We're like, well, it's not the patient problem.
No,
It's a system problem. Let's find a solution. Let's look at something. Let's stop blaming the patient.
And that's what we did. We opened up some withdrawal management beds at our hospital. We went up to our hospital in 2020. Louisa and I spoke to the CEO and senior management, said, we need to do this. We need to do this to start saving lives. So they actually gave us 2 beds. So for 2020 to 2021, we had 2 beds to work out of. But of course, if these beds were full, the emerge docs were so good now, they'd keep the patients until a bed opened up somewhere. And we'd admit them anywhere in the hospital we could, because if they went home, we knew their chance of dying was quite high. This is a medical emergency. So now the emerge docs knew, you know, just like we keep chest pains when we don't have a bed, we keep them in the emerge department until something opens up. We were doing that in our department as well. And right now our beds, we now have funding for 7 beds, and it's going up to 14 in the near future. So all these beds now are staffed by nurses who have been trained how to use buprenorphine for opiate withdrawals. And we have a physician on call 7 days a week, and we have dedicated nurse to our program and a dedicated social worker. And they're all followed up by our community withdrawal management service as well, which is an NP, a social worker, and a nurse who sees patients in their home if they need to.
And we proved to our hospital that this was worth it. And they realized that this was worth it.
So what did we do? So initially, this is our protocol. This is where the big bucks that you guys want to know about. So initially, what did we do? Well, what we do is we didn't know what we were doing. So in 2020, we looked at protocols out there. So we found the Alberta the College of Family Physician of Alberta had this protocol out. We said, okay, well, let's do this protocol. We put it up in the emerge department. We started using it ourselves in the hospital.
We put up sample prescriptions of Suboxone taped up on the wall in the emerge.
Microdosing prescriptions versus this titration. And what it was really slow titration. So we followed the protocol. So they got the 4 milligram dose on day 1, and then some PRN doses every hour. We had a max daily dosing on day 1 of 12 milligrams, day 2, 16, day 3, 20, day 4, 24. Well, what do you think happened? Patients would leave.
They felt terrible. They didn't stay on treatment.
It would take us hours to get to 12 milligrams, right? So they feel like crap. I didn't want to stay. And then we said, okay, well, you know what? We'll get you through this over 4 days of feeling shitty. And then we'll get you to come back for your depot shot, because we have to be on it for 7 days.
Because the product monograph says you have to be on Suboxone a minimum of 7 days to get the buprenorphine or Sublocade injection.
So we said, come back in 7 days and we'll give you your injection. What do you think happened? they wouldn't come back.
They couldn't come
Right?
back. They were feeling terrible because we didn't titrate them quick enough on Suboxone. So they left and never came back.
And then the nurses would say to us, why are you guys going so slowly? They all end up needing
Yeah.
24 milligrams by day 4. Or the patients would say, doc, why are you giving me 2 milligrams? I take at least 8 milligrams at a time on the streets. We're like, yeah, why are we doing this? So we started looking at alternatives and why we were doing this and why it wasn't working.
So as Guns N' Roses would say, we used to give this is Mr. Brownstone. We used to give a little, but a little wouldn't do it. So a little got more and more. I just keep trying to get a little better. That's mine and Julie's
Yeah.
little motto. So what we're trying to say is we used to give these little doses of Suboxone, and then we started listening to patients and nurses saying they all end up on 24 to 32. Let's just give them that. We were like, good idea.
Oh, and we were just going to 24 milligrams.
Oh,
right?
yeah.
And patients would say, I'm still feeling crappy on 24. So we're like, well, why are they using 32 in the States? Because we started Googling things and looking into other protocols. We're like, well, if they're using it, so are we.
So we started using it.
32 milligrams.
So it was a game changer. So then we started terming it macrodosing because we started realizing if we just gave patients one big dose, macrodose of Suboxone all at once, when they were in withdrawals over 18 to 24 hours or fully reversed on Narcan, we would give them one big dose, and within 30 to 45 minutes, you could have a conversation. They didn't want to run out of our merge. We could talk about treatment plans, housing, what was going on in their lives. We even had patients that needed protection from a few female victim services getting involved, human trafficking. We could actually have conversations with our patients. So sometimes you have to go higher than 32 milligrams during the stabilization phase, but we started noticing that if we gave higher doses, people stayed and we can have discussions with them. And we give a total dose of 32 milligrams. Well, now I give 32.
Yeah, we often give 32, but
once.
Our protocol now states 24 milligrams for the first dose.
Yeah.
And then an hour later, they can have another 8 milligrams to 32 milligrams. So within 1 to 2 hours, their withdrawals and their cravings are well controlled. And if they need more, our nurses will call, listen, I think they need more. We will give more PRNs that first day to 44, 48 milligrams, sometimes higher. And what we often do as well, we add Valium now because of all the benzos, right?
And a lot of times they'll tell us, I feel good from an opiate standpoint. The patient will tell you, but they're like, there's something a little off. And we give them a dose of Valium. It's because when we look at their urine, the reason why we do our urine drug screens when they come in is we like to see if there's benzos in their urine because it changes our treatment of the patient. That urine is not to say, to be punitive in any way, but a lot of our patients will have benzos in their urine and they will tell you they don't use benzos, but it's in the contamination of the fentanyl. So we give them, we call it the Ken Lee approach.
Yeah.
We give 10 milligrams once a day for 3 days for the benzo withdrawals that sometimes some of our patients feel.
Even if their urine is negative for benzos, because we know they're not all picked up, we often give Valium once a day for 3 days. If they're still feeling kind of irritable and anxious after they're maxed out on the buprenorphine. So these are for patients who use fentanyl, right? We have patients who abuse Percocet. We're not doing this with them, but within 1 to 2 hours, they're well controlled. As opposed to, it used to take us to
4 days sometimes to get people
to 24 milligrams. They used to take us 7 hours to get to 12 milligrams on the first day. This is ridiculous what we used to do, but that's all we knew, right?
Yeah.
So we had to change by listening to the patient and the nurses.
These are just some sample order sets. This is what we're using. We're changing these all the time. Our nurses want to kill us, but it's important to change. We've changed this protocol 5 or 6 times within the last year. And now we have it broken down to those who use fentanyl, those who use other opiates who are coming in for treatment. And what we have learned that clinical observation, we talk about practicing evidence-based what's the evidence, but sometimes the urgency of this crisis supports practice-based evidence. We have learned as we have gone along what has worked. And sometimes that's what you need. There isn't always evidence. You have to do sometimes what is right and what you're seeing in front of you is effective.
And really, we learned from our patients.
Oh, big
telling
time.
us this is not enough. I'm going to leave doc. So we had to change what we were doing.
And we've seen we say 180, but now it's way over that. But what Julie and I have learned is we have never given too much buprenorphine naloxone, but
we have given too little.
And the nice thing is when you macrodose people, we find the more we macrodose and give these big doses, the less likely we're likely to see precipitate withdrawal. And, this is just to talk a little bit about this. I know I don't want to get too far behind, but Julie and I, when we present buprenorphine naloxone to our patients in the eMERGE, we don't really discuss precipitate withdrawal. The reason why we don't is because we know how to treatment. And if you say to a patient, you might go into precipitated withdrawal, I'm a bit nervous giving you, they're going to say no. But if you present it this way and say, we're going to give you buprenorphine naloxone, usually if you're 18 to 24 hours after using fentanyl or you're fully reversed, when we give this, you shouldn't feel sick. You should be okay. But sometimes in some people, you do feel sick, but we know how to treat it. So I'm going to give it to you. And if you start to feel terrible, we're just going to give you more. And they say, well, more, won't it make me feel sick? And we say, no, the more we give you, the more it covers the receptors. It's all in the presentation to the patient because they also know about precipitated withdrawal. So like Iggy Pop, what we're trying to do for our patients is give our patients a lust for life, and we want them to be successful in whatever treatment strategy they choose.
So before we start doing this, we started looking at evidence, right, to make sure we're doing this, we're doing the right thing. We met with people. We met with different addiction specialists in Southern Ontario. We met with Dr. Ruben Strayer in the States.
Mel Cahan, Jennifer Wyman,
Right.
Ken Lee.
So
We even spoke with Andrea Sarita. We spoke with all sorts of people.
So this is just some of the evidence that's out there. Again, these are mostly, retrospective case reports or just case reports. There's no randomized controlled trials right now looking at high dose use of buprenorphine. But Andrew Herring published this. This is from an emergency department where over 390 patients. And what they saw that single dose, they compared single dose, low dose 12 milligrams versus higher dose. And what they saw is that higher dose up to 32 milligrams is lower dose is 12 milligrams is safe, well tolerated, and protective, and is effective at blunting the euphoric effects and also the withdrawal symptoms, and that their patients were in the emergency department less than 3 hours.
Because that was always a complaint by the eMERGE docs. Well, these patients take so long to treat in the eMERGE, and Julie and I have proved, no, actually they're in there way less. Some people are in your department for UTIs more than 3 hours. These people can be in and out in less than 3 hours.
And safe, no respiratory depression, these patients on the high dose.
Yeah.
Also, we looked at these kind of case reports. This was a single high dose buprenorphine for patients with opiate use disorder, where they compare patients getting 32, 64, and 96
milligrams.
And what they saw is that the higher dose had better improvement in their cravings and retention to treatment. That's 96 milligrams with no respiratory depression. Other studies as well, looking at higher doses, 16 versus 32 milligrams, less dropout rates at 7 days with the higher dose. And that patients on 32 milligrams, again, heroin patients, I think there was only 10 patients in this case report, but all absent at 7 days, and safe. This is what we want to make sure. We want to make sure
what we're doing is safe,
right? So it's the most common side effect we would say is nausea. So that's what we found in our patients. And this is a very interesting thing that's going on in the States right now that we're trying to get started in Timmins, is the use of buprenorphine post-naloxone reversal in overdoses in the field. So what they're doing here is the paramedics are giving high dose buprenorphine, 16 milligrams followed by 8 milligrams with wraparound services the next day for addiction treatment. So they're doing this in the field, and
you guys might be coming near you very soon.
Right,
Timmins is hopefully the pilot project for this.
So again, when we were looking into this, we found these protocols, California Bridge protocol that used 32 milligrams of buprenorphine. And as well, this great protocol, which now Medify has it, and Jennifer Wyman's on here. We just published similar protocols for post-naloxone reversal.
You should see its beautiful algorithm.
If they come in, and we didn't have time to put on our presentation because we were away, but really, if patients present to your eMERGE department fully reversed after naloxone, not a little titration of naloxone to get them breathing, fully reversed, and it's severe withdrawal, and it's within an hour of getting their naloxone, give them 32 milligrams of buprenorphine. So you can do 16 and 16. We just go 24, 32 right away, and it's a game changer. Patients are feeling better within 30 to 40 minutes.
And even if they don't want treatment, you have made them better. And the other thing is the argument to eMERGE docs say, well, that patient always come back. You give them Suboxone, you've protected them for up to 24 up to 48 hours from overdose.
Yeah.
So if they go out and use again because you've taken away their opiate tolerance by giving them Narcan, they're not going to die.
Right. They're covered with the buprenorphine on the receptors. So it's protective. So you're giving them a life-saving medication for a life-threatening illness. And it's great when it works.
Yeah.
When you use it, you'll be loving this.
So when we look at early depot, so we're talking about injectable form of buprenorphine, which is called Sublocade. Julie and I started realizing, okay, there was this arbitrary
7 days wait.
Yeah, on the product monograph, you have to wait 7 days. And Julie and I were like, well, if we're doing macrodosing, so what's the difference between 7 days of 8 milligrams of Suboxone, or if I'm giving someone 32 milligrams, why do I have to wait this arbitrary 7 days? And some of our patients, if you can imagine, if they come in and they're in withdrawals and I give them 32 milligrams and it's 10 p.m. at night, the next morning, I will give them another 32 milligrams. They're getting 64 milligrams, sometimes within 12 hours, 64 milligrams in 12 hours. What's the difference between that and 8 milligrams over 7 days? So we started thinking, well, for macrodosing these patients, let's just start giving them early
injection.
And we started initially, we were quite nervous. We said, okay, 7 days, let's give early 5 days. And then we're like, 4 days, 3. And then next thing you know, we're giving some people, patients of ours who know about the program, they actually show up in the emergency, they say, I just want the Suboxone and I want the buprenorphine, sorry, I keep saying Suboxone, but buprenorphine naloxone. And then I want the injection and then I want to go. And we say, why not? We give 32 milligrams in the emerge. An hour later, they get the injectable form of buprenorphine and they're gone. And it's because many of them have heard it. They heard it through the grapevine, through their friends. I want the injection. They can still use drugs on the injection, but the difference is they don't die from opiate overdose. It gives them choice. You know, it's interesting working in corrections. I have patients who come in now who are on the injection. You know what they say to me? Before they would come into corrections and they'd be in terrible withdrawals, nausea and vomiting. When they're on the injection, they have no withdrawals. The other thing it gives them is choice in the sense that if they have no money to get drugs, they don't have to rob a store. They don't have to do any of those criminal acts to get money for the drugs. If they run out of drugs and they are on Sublocade, they don't go through withdrawals. They don't get dope sick. So sometimes they go 3 or 4 days without using fentanyl. So when we look at evidence for depot buprenorphine administration, this is one very small study that was used. And again, Julie and I looked at these small studies because it gave us a glimmer of hope that what we're doing wasn't crazy. We weren't totally cowgirls. And again, this was another example of a single day induction, which we were doing to say, okay, this is safe. We wanted to make sure nobody was dying getting early depot buprenorphine.
So these were all studies that were ongoing that weren't published yet, but we could tell, okay, people are starting to do this. Okay, the studies are ongoing. What we're doing is probably okay.
Yeah, we're not going to kill anybody. And then again, what we also found that evidence for early depot buprenorphine did have some protective effects against overdose, like methadone did. Oh, sorry, I'm on slide again. Like methadone does, and like buprenorphine naloxone. So we're starting to see some evidence emerge that it is safe and it is somewhat protective. So is it still me?
So this is the game changer, right? So what we did is we start giving it early. So patients come in, they're stabilized, and then they get their early buprenorphine sometimes the same day, and then they're gone at their request. If they have a lot of social issues, we like to keep them.
If they need sort out housing, they need disability forms, whatever, we keep them. But some of our patients
don't want to stay, and that's okay. So we do this quite quickly now. That allows them the choice of either staying in our detox unit or going back into the community and following up with our team at that time.
So updates from our hospital. Is it here? Where are we? Oh, right here. Sorry. Updates from our hospital. So this is 2021. We don't have our 2022 full data yet. Obviously we will in December, but we had a total in 2021. And remember, we started with 2 beds in 2021. These are the numbers out of 2 beds, not 7 beds that we have now. We treated a total of 148 patients. And 120 of them, 21 of them were opiate use disorder because some had alcohol use disorder. Our average length of stay was 3 days, which is amazing. And that included our alcohol use disorder.
Yeah, they usually stay 5 to 7 days.
They take
right?
longer. Of the 121 patients, 94% were started on our macrodosing protocol of buprenorphine naloxone. And of the 114, 87, 76% received depot buprenorphine, which is huge, huge numbers. So within our own hospital, we gave a total of 122 doses of depot injectable form of buprenorphine. 87 of those doses were out of our 2 beds in our acute withdrawal unit, and 35 of those doses, because what happened is when Julie and I opened up these 2 beds, other services in our hospital started saying things like, you know, so-and-so came in with an acute cholecystitis and has opiate use disorder. Can you come and see them? And we started now treating people all over our hospital very similarly under different services. So from March to July, this is crazy. So in all of 2021, we saw 122 patients, or 148, sorry, 148. From March to July of 2022, we saw 121. Our numbers have gone up substantially since we started this in December of 2020. It's gone, and now we have 7 beds. So remember now, as of 2022, we have 7 beds instead of 2. We had 77 were opiate use disorder, 44 were alcohol use disorder, length of stay of 3.4 days. Buprenorphine starts, we did 60. That is the macrodosing, 78% of alcohol use disorder admissions. And for the buprenorphine injectable, 52 people received it before leaving the hospital. So when we look at our reflection from the past and the present, it's crazy. You know, in hindsight, we think, what did we do before? Even our nurses in the emerge, the doctors in the emerge, what did we do for these patients before? You know what's really sad? These people would come into our emerge and get zero care, really. And it's devastating for us to think that we did nothing for these people before. Now people say things, wow, I haven't seen so-and-so in a while. How are they doing? And we're like, oh, they've been on treatment. Or they'll say, so-and-so came in yesterday, not with an overdose, but with an infected toe. You know, these are amazing things. We no longer send people home because we say our beds are full. That doesn't exist anymore. If someone comes into our emerge and asks us for help, that person, and they want to stay, not everyone wants to stay, and they want to stay, we find them a spot, whether that means holding them in our emerge under us or holding them somewhere else. So when we look at reflections of the past and the present, our patients say things like this: I've never felt this good. I was using a gram of fentanyl a day, and now 48 hours ago, like 2 days ago, I was using a gram of fentanyl a day, and now I have no cravings, no withdrawals. They thought it was going to be impossible. They look at this as weeks to months of getting out. We're talking about the acute phase. I mean, we have the other phases, the subacute phases. We're not talking about that, but we're talking about the acute stabilization of phase of those people who are coming in asking us for help.
So this is now we get patients coming in now to our emerge department asking this: hi there, I'm here for Suboxone injection. So right now our patients, our nurses know to give us a call, right? Before they'd be like, what do you mean here for an injection, right? But now they know, okay, they missed their injection, they'll call us, we meet them in emerge and we give them their injection. But they come in here, asking for Sublocade, asking for the injectable. And what's nice is the word's getting out that we are open to that, and we are here to help them. They can come anytime requesting help. We will give them the help they need.
And I love this second one. States he's going to be traveling out of town. This is the freedom it's given to our patients. Our patients now come in and say, I need my Sublocade injection early because I'm going to Toronto with my family. It's we don't have to stress about trying to find them a pharmacy or they have to run to the pharmacy and get their carries to go to wherever they're going in Toronto. It's been a fascinating change. So what we have learned and what are our take-home messages?
Listen to the patients. That's why we changed our protocols. We weren't doing it, we weren't treating them adequately. So we had to change what we were doing because the patients were saying, I'm going to leave. Don't be afraid to push larger doses of buprenorphine for your induction and for precipitate withdrawal. It's safe, no respiratory depression that we've seen. We've used, I think the highest dose was 105 milligrams, something like that, 104 milligrams. Buprenorphine needs to be the standard of care in emerge. Consider giving early depot shots within 24 hours. We've given it within 2 hours of their buprenorphine sublingual. Think outside the box and be more flexible, and continue to work on stigma, reducing stigma and barriers associated with addiction in your healthcare setting.
And
Oh,
take
yeah.
home messages. Oh, we have one more. We
Quickly.
missed one.
Treat them and treat them can no longer occur.
No longer saying to patients, we don't treat addictions in our emerge.
Yeah.
We
no.
you can't be saying that anymore.
We're in the business of saving lives.
Caring for people.
We don't get to choose whose life we save. We save everyone's life, including people with addictions.
Julie and Louisa, can I interrupt?
Yeah.
Sure.
Because there are tons of questions.
Oh,
You
okay, we're almost done. We have
Okay,
literally 30
okay, very
seconds
good.
left. 30
Okay,
seconds.
we're at the,
So-
okay, go.
Okay, and then just to go back one more. We
Patient,
always
yeah.
say it's not a patient problem. It's a system problem. We're always blaming the patient, saying things like, why are they still using drugs? They've overdosed. Why aren't they getting help? How come they're not at their appointment on time? We're like, that's not a patient problem. That's a system problem. We need to be going to the patient. We need to be asking the patient what works for them. Stop blaming the patient. And we always say, if Timmons can do it,
So can you, and so should you.
and so should you. So like
Yes.
Tom Cochran would say,
Have no regrets.
I have no regrets. And as Keith Richards would say, that's right. Oh, we put doctors because, we're talking to other people too, but that's right, doctors. I made it another year. I still can't believe this guy's 80 and still a rock star. Any
So-
questions?
Okay, so there are many questions about specifics of the protocol. I'm wondering maybe to kind of cover them all. Is there a place that one can access details of the protocol?
Yeah, so just email us and we'll send
Okay.
them the protocol. We'll send the order
Okay.
sets for sure. Yeah, no
Okay.
problem.
Okay, excellent. I'm trying to go back to the beginning, but we're getting, well, just Zoe has one regarding retention. Do you have any evidence regarding retention using these protocols? Go ahead.
I want to say hi, Zoe.
So
That's Zoe Dunn.
Yeah, anecdotally, we are seeing great retention because Louisa sees a lot of these patients in her community health center, and our team, community withdrawal
Mhm.
management, follows them. But we are doing a study now, right? So
Okay.
we are doing a study with Women's College looking at healthcare realization and retention to treatment program versus the
Just-
year after a program.
And if we
And
get
that-
asked to present next year, Zoe, maybe we'll have the data for you.
There was also a question. I know, Louisa, you're working in prisons as well. The one person commented that they're not able to use the Sublocade earlier because of the formulary. Is that
No,
No,
not
Okay.
Louisa.
This is what I say. We're the physician. And Julie and I have, if you need a million reasons to do something to save a life, we have those for you.
Yeah.
So our argument is all the time. Someone who can't breastfeed, what do we give them? Domperidone to breastfeed. That's off-label use. People give, and domperidone causes QT prolongation.
Yeah.
It causes way more side effects than an early depot Sublocade prescription. People give ASA for carotid artery dissection. There's not even evidence.
Also, there's often off-label stuff. Just there's no reason why you can't do this in corrections. Louisa does it in corrections all the time.
Because
Okay.
I think what we need to remember is, as a physician, our job is to save lives and do no harm. And yes, people, it's like any medication. People are allowed, there's guidelines. These are guidelines. But as a clinician, we still need to make clinical decisions. So I will say most of the time in jail, people do end up on 7 days of buprenorphine naloxone because it's jail. But I have people who come into jail who are getting released the next day who say to me, I need the injectable form.
Right.
When I leave, I'm going to die. How do I say to that inmate, shoot, you know what? I'm going to have to keep your risk of death high and not give you that injection. It's 7 days on the protocol, right?
Forget
Like,
that.
forget
Yeah.
that.
No,
They're going
so
to
it's
die.
done. Yeah.
They're using off-label use of fentanyl every day. If I know an inmate's leaving and going to
Next
die,
question.
if I know,
No,
an
I think this is great. And you're saying that with this protocol, you can do that for this person.
Yes.
oh
Yeah.
yes,
Yeah.
because
Okay. No, that's fantastic. There are lots of other questions regarding doing this in the office and in the community setting.
we do it.
Yeah.
We do it all. So
We use this protocol all the time. We use it. You know what we do here? We treat patients in the local jail. We go and give them high dose macrodosing.
and sometimes Sublocade in our local jail because they're being held until they
to go to court.
Yeah.
So we do this in the jail, guys.
Virtually?
No,
Uh,
no, our nurse.
No.
practitioner-
There was another question about what
Oh.
about doing it virtually?
Well, we
Yeah.
do it virtually for the coastal community. So
Okay,
Yeah.
there
so
we go.
the James Bay Coast, they will be on the OTN with us. The nurse has been trained.
There's a
and we-
nurse there. Okay, yeah.
Yeah, the nurse
Okay,
will do
yeah.
the injection, and we're sitting there on the OTN.
Fantastic.
Once a nurse is
Fantastic.
trained, we don't need to be sitting there doing the injection. That is a nursing skill. It's
Okay.
actually, it's interesting. It's actually the prescriber that needs to be trained, not the nurse. But anyways, that's a whole other
Okay.
thing.
And lots of questions about in-services. Are you available for in-services?
Sure. Yeah, we can help
Yeah,
out. Our
okay.
nurse can help out possibly. Our team can do an in-service with your staff.
Okay. I'm looking through more of the, are you doing traditional dosing at all still?
Yeah, for Percocets.
Percocets,
Percocets?
Dilaudid.
Yeah, the
Okay.
coastal communities up north are, you know,
Okay.
they have
Yeah.
Percocet use. So we do like the 4 milligrams with PRNs during the day.
Yeah.
And yeah.
Yeah.
Okay. I'm just amazed. Oh, there was a question too about how often you're doing the cows, but again, that's to the specifics of the
It's on our
protocol.
protocol. It's
Yeah.
on our
On the protocol.
protocol. Yeah, yeah, no, the nurses know when to do it, when to start doing it.
Am I mistaken? Is there not a macrodosing protocol too on the Medify website?
Yeah,
Yes.
that's what
Yes,
we worked
there
on.
is.
That-
Okay,
yeah,
okay,
we
okay.
worked
So
on
good.
that.
Yes. Okay. So the
Yeah,
Medify
no,
as
and
well. Okay, that's fantastic.
post-naloxone. Yeah,
I-
post-naloxone.
Because a lot of bystanders are administering people naloxone, and that's when they get fully reversed. Typically, if EMS sees somebody and they're breathing, they don't fully reverse that individual. They titrate them to maintain their airway and not necessarily fully, because they know that if you fully reverse somebody, it decreases their
Yeah.
tolerance and their risk of death is higher.
Gi-
So full reversal.
Jillian
Yeah.
Cola says also interested if there's any data on rate of overdose in 3-6 weeks post subcutaneous dose.
There's very, very preliminary data, and we showed that was on one of the slides. It's
Okay.
a poster presentation, and what's interesting, what is trending with depot buprenorphine is that it is probably just as protective as methadone and sublingual buprenorphine
Okay.
naloxone to overdose.
Okay. There was a question earlier on about, oh, sorry. There are more questions coming up, and we have 2 minutes left. I don't know if we're so many questions. It's great. Well,
We do this as outpatients. We do this as
Mm-hmm.
inpatients. It's for fentanyl users, people who use fentanyl. You know, you can use macrodosing in your office. Like, there's
I
no
have
problem.
patients who I say, come back tomorrow morning. They see them at 9 a.m. one day. I say, come back. I give them a prescription for 32 milligrams. I say,
Yes.
no fentanyl after 9 today. You saw me today. I try to get them to at least 18 hours. I say, take the 32 milligrams 18 hours or more after you last used fentanyl. Come back at 9 tomorrow morning. That's 24 hours. They take their 32
Oh.
milligrams. I give them depot buprenorphine in
I
my office.
almost forgot the evaluation. Please fill out the evaluation, please. Everyone, I just put it in the chat. I'm going to put it in again. Thank you so much, Julian, Louisa. Amazing stuff. And thank you everybody for incredible questions and discussion.
Thanks, Josh.
Thanks.
Oh, my pleasure. My pleasure. Really. Again, here's the evaluation form. I'll just type that in. Okay. Thank you, everyone.
No problem. And we can present to your groups anytime.
We've
Just email
presented
us.
to lots of emergency physicians. It's been they've been very receptive.
Okay. Thank you. Okay.
Great.
Bye-bye.